Hello, and welcome to my podcast channel. This first episode is all about how I diagnose clinically and what this process looks like. And in future episodes, I will be going over many different diagnoses from lower back pain, headaches, neck pain, knee pain, hip pain, and so forth. At the same time, if there is any topic any of you guys want me to cover, please feel free to comment below. I would be more than happy to do so. So let's dive into the first section. As I have just said, this episode is aimed at outlining how I diagnose in my clinical practice, and arguably why other clinicians should also follow the same process. In my clinical experience, I have rarely seen many professionals follow a structured process, let alone a process at all in some cases. One very good example of this phenomenon is using medical imaging alone to diagnose conditions. Imaging is one of many tools that is sometimes needed in order to diagnose, and should not be used on its own as it so often is. There are, of course, rare examples of when this rule may not apply, such as when a patient is in a coma or has been knocked out and cannot talk to you. Before I start with the first component, there is a small caveat to be aware of. Any suspicion of red flags allows the clinician to divert from the format in order to then subsequently confirm or reject these red flags. In short, red flags are diagnoses that have a poor prognosis and require immediate attention via further investigation and/or treatment. Essentially, one has to resolve these with urgency before moving on. These red flags tend to be life-threatening or seriously debilitating in nature. Only in these situations should you deviate from the format I am about to explain. Some examples of these red flags include Cauda-Equina syndrome, suspected heart attacks, strokes, fractures, and so on. With that being said, let's dive into the first component. What is a diagnosis, and why bother diagnosing at all? We should all be aware of the golden rule stating that one must have a diagnosis in order to treat. Without a diagnosis, we have nothing to treat. In its simplest form, diagnosing is about generating several hypotheses about what you may think is wrong with your patient. This is known as a differential diagnosis. You then test for which of these may be most applicable and subsequently to treat based on this hypothesis. If you are right about your hypothesis, i.e. your working diagnosis, then your treatment will address that diagnosis and thus the patient will get better. In reality, however, it can get much more complicated, especially with chronic multi-system disease. That is why using the process I'm about to explain is critical for achieving an accurate diagnosis. Without it, we run the risk of not only missing the correct diagnosis, but potentially harming and endangering our patients in the process. Unfortunately, I have had colleagues in the past that I've had to deal with this exact burden. To briefly explain one of the cases for context, a blood clot in the calf had travelled to the lung, causing sudden death after a sports massage. This is known as a pulmonary embolism. The patient had been complaining of a tight calf muscle after having travelled for work. The therapist didn't do a case history, having just started massaging the calf as part of their treatment. If the therapist had spoken to the patient first, they would have had a suspicion of a pulmonary embolism due to the following risk factors: recent air travel, smoker, overweight, and a history of pulmonary embolisms in the family. I cannot emphasize enough the importance of following this step-by-step sequence to diagnosis. I am going to frame the following process based around a general musculoskeletal complaint such as back pain. Obviously, some of these questions may not be relevant to all non-musculoskeletal diagnoses. However, the format still applies regardless. The questions you ask are based on what you think may be wrong at each given moment with your patient. This is your working diagnosis. It is always an ongoing process. Even treatment itself is used as a diagnostic tool. With experience, you can start to ask different types of questions that cross-reference many systems at once. You build on your questions as you interact with the patient. The detail of what you do and the questions you ask within this process can be very different depending upon what the presenting complaint is. So this process can be split into 5 main sections, and I plan to go through each and every one of them. A full case history, examination or testing, your diagnosis, the treatment, and the management plan. Let's start with the case history. The first job is to greet the patient, welcome them, explain the process, and gain informed consent. Ask them if they have any questions before starting, which addresses all sorts of stuff from nervousness to anger, which can really get in the way. So addressing this at the beginning is critically important in some patients. Then you can start to rule out the red flags and make sure that your patient is appropriate for your scope of practice. The first section in the case history is known as the presenting complaint. This is about what the patient came to see you for. There are many ways to do this section. You can ask a set number of questions that you should ask, or you can let the patient talk about what is wrong, tell you their story, and note down the key parts of what they are saying. Both work. It just depends on your style and what type of patient you have in front of you. A talkative one, an angry one, a dismissive one, and so forth. The questions you should ask relate to trying to understand what is going on with your patient. And these are, number 1, what, when, and how did it happen? Number 2, how has it affected your day-to-day? Is your function affected? Number 3, is it getting better or worse? And how so? Number 4, any neurological signs or symptoms? Number 5, any associated signs or symptoms? Number 6, what is the quality and nature of the pain or dysfunction? Number 7, have you had this before? Number 8, what are the better for or worse for factors? Number 9, previous history of pain and interventions of all types. Number 10, what are you expecting in coming to see us? Number 11, what are your concerns and beliefs about what happened? Number 12, how bad would you say this pain or dysfunction is on a scale of 1 to 10? Number 13, is there a daily pattern? Number 14, occupation, history. As a side note, one does not have to ask these in that particular order. Once you have completed that part, you can move on to the medical health history. One needs to inquire about the following subjects: smoking and drinking, accidents, illnesses, surgeries, investigations, blood tests, CT scans, MRIs, X-rays, all of them, and for what for? Medication that they're currently on or have taken, family history, nutrition, diet, lifestyle, and exercise. Next is your systemic inquiry. These are specific questions related to various systems in the body, such as asking about dizziness and low blood pressure. General questions should be asked to all patients, irrespective of their presenting complaint. More detailed and specific questions must be asked when you are clarifying the diagnosis, or there are many things going on in such a case of a multi-system disease process. For example, calf pain on walking up a hill can be a completely different diagnosis to calf pain when walking down a hill. You would use a focused systemic questioning to figure out if the calf pain was vascular in nature, i.e. up the hill, or mechanical in nature, i.e. down the hill. Without looking for these risk factors, you cannot know which differential diagnosis to follow or reject. These categories are as follows: cardiovascular, respiratory, endocrine, gastroenterology, urogenital, gynecological, bowel and bladder, psychosocial, and then other. In the other category, everything else fits there, such as headaches, constitutional symptoms, sleep, stress, vision, ears, energy, pregnancy, children, bruising, general well-being, and so forth. The last part, and one that is very important, is to ask the patient if they have any questions or anything else to say or add before moving on. You would be surprised as to how many times patients have said something to me at this stage that has changed the entire diagnosis and course of action. The next section is examination/testing. The first job is to explain what and why you're examining or testing, the risks involved, alternatives available, and subsequently you then gain informed consent. Again, very important. Your examination or testing is used to confirm or reject your working diagnosis. This means that your testing has to be directly relevant to what you think may be going on with your patient, not just testing random stuff. It is well known that you have no idea what is going on after the case history and just start testing for pain or dysfunction, that it will most certainly lead you and your patient down the wrong path. For example, most people with back pain have sore points on their back, yet these sore points often have nothing to do with the correct diagnosis. Examination always starts with observation, and this happens from the moment you first see the patient, walking across the car park, getting out of the car, so on. Generally, you look for things such as rate of breathing, their complexion, their gait, their skin, nails, hair, body type, behaviors, general vitality, and so forth. Generally speaking, one starts with checking all vital signs in every patient. I cannot tell you how many times I have found very high blood pressure in those that are medicated and monitored by their GPs. Next step is to have a closer look at the patient. Antalgic patterns, postures, any irregularities, swellings, and so forth. You're observing everything you need to in relation to the context of your working diagnosis. This is not a random observation. Once observation is completed, we then feel, palpate, or reproduce symptoms if warranted. General medical screening can be done first here if indicated. This can be anything from abdominal palpation, checking for ascites, to palpating the lymph nodes. Next, you palpate more specifically. For example, if someone had back pain, you would palpate each spinal segment and corresponding areas. If someone is complaining of reflux, you may want to palpate the epigastric region more closely. For musculoskeletal complaints, you can now move on to passively moving body parts and do orthopedic testing if necessary. You are looking for exact pain reproduction, dysfunction, and so forth. Remember, all that is relevant to your working diagnosis, proving or disproving them along the way. If your working diagnosis is neurological, you use neurological testing. If you think it's vascular in origin, then you do vascular testing, and so forth. You get the idea, hopefully. The examination is complete once you are happy that you have arrived at your most likely diagnosis for that patient. The next section is explaining your diagnosis to the patient. You need to explain this in clear, easy to understand language that the patient can fully understand. Again, in my experience, I've had far too many patients come along with their associated diagnoses for 20 years, of which they have no idea what it means. Confirm that they have fully understood what you have said and what it means. You can even get them to paraphrase it back to you, which can be useful in some patients. Remember to ask and answer any and all questions that present after this, and subsequently explain the prognosis. Once the diagnosis is established and the patient is happy, you can explain what the appropriate treatment is for their diagnosis and make sure they are fully on board. If it is exercise or rehab, for example, make sure that they know how to do them properly and will they actually be able to do them. Explain any and all risks, alternatives, and benefits. Make sure they know 100% what they are expected to do. If the treatment is manual therapy, then make sure you gain valid consent and explain treatment side effects, reactions, risks, and benefits on alternatives, and so forth. The last section is the management plan. This section is all about the mid to long term and essentially allows the patient to not only fully heal from their presenting complaint, but also be much better off. For example, if a patient comes in with back pain, your management plan should aim to make sure that the patient never injures themselves in that same way again, but to also be much more resilient in the future through, for example, through the exercises you have prescribed or the key information you help the patient understand. Ask if they have any questions before they leave, and if they're happy with everything that has been explained, and that they understand what they are expected to do and how long it will take for them to feel better. As you can see, there is a thread that runs through this whole process from start to finish. You cannot skip bits out for this reason and for the ones I have already explained in this episode. You can, however, do the history in any order which you like. You may think that this process takes a long time to do, but rest assured, with practice, it does not. Obviously, if you have a complex patient with a lot going on, it will take some time. But this is exactly the time you should take with these patients. Cutting corners is not worth the potential consequences of what may happen, especially with complex presentations. Do it right the first time, and you won't have to do it again. This process also builds an immense amount of trust between you and your patient, as most are very grateful you take the time to go into this level of detail. Ironically, there have been quite a few times where a patient has already felt so much better before anything else has happened, just due to this process alone. As such, I hope you have enjoyed this episode, and if you have any questions or comments, please feel free to leave them below or get in touch. Take care.